Welcome to the Doctor Coffee Podcast, Dr. Lliam Brannigan. Good to have you here, sir.
Thank you very much, Simon. It's an honor to be on the podcast, and I know it's taken a while for me to get organized, but thank you very much for the opportunity.
It's a wonderful privilege to have a heavy hitter such as yourself on the podcast. Looking forward to learning from you and growing from the conversation. So, the start of every podcast episode with our consultant guests, start off with a very easy question to ask about where you went to medical school and your junior doctor years, so particularly internship and ComServe. So let's start there, where you graduated from and where you did your junior years.
Okay, so I went to Wits. I actually started out at Pretoria University for about 6 weeks. And then I got a call to come to Wits, and off I went. And so very proud Wits alumni. And when I finished at Wits Medical School, I then went down to Paarl Hospital to do my internship. That would have been 2002 to 2003. Had a great year in Paarl. What an amazing hospital. And then I got third rounded on my comm service rota, and I got sent to Bethesda Hospital in Northern Natal. And mentally, I went there kicking and screaming, but turned out to be the most amazing year of my life. It was very good to be in the hardcore rural northern KwaZulu-Natal, really embedded into the Zulu community there, and then actually got an opportunity. So during my medical school years, I worked on the road a lot and used to dispatch the old Echo 1 helicopter, which used to reside at the back of what's now CMJH, in those days, the Joburg Gen.
Oh, wow.
And in my comm service, they had a problem with clinicians' availability for the heli. And so I got sort of fast-tracked to do that. So on my weekends off, I used to go down to Durban, and I started my heli flights there. I probably did 50 flights or 40 flights in my Cosmo year for what was then, I think we used to call it Echo 3. Because Echo 1 was in Joburg, Echo 2 was in Pretoria, and Echo 3 was in Virginia. And then when that was done, I came up to Johannesburg and worked in 163 in the old trauma unit as a medical officer, and was flying on the heli then.
Wow.
As a heli doctor, and then went off with South African Search and Rescue to the earthquake in Pakistan in 2005, which was a really amazing experience with one of my best friends and a rescue team there, about 50 k's from the epicenter of the quake. And then I started my reg time in anesthesia. I was always going to do critical care, but it was either going to be medicine, pulmonology, and critical care, or anesthesia and critical care. And at that time, my now wife was very keen to embark on a medicine career, and I didn't think it was a great idea for both of us to be physicians. But also, I love the resuscitative side of anesthesia, so I took a reg job in anesthesia. It was very junior, very undercooked, but somehow managed to get through that. That part one is something else, and managed to pass it first time by some miracle. And then became an anesthesiologist in 2009, and then straight into a critical care fellowship, and lots of things since then. I mean, I ran an ECMO unit for a few years, and did some training in the US with that, I was very lucky to be given that opportunity. Very short for a couple of weeks, but it was still very good. And then got called back to Donald Gordon in 2018, I think, to run the unit there. And I have a whole team of intensivists, both physicians and anesthetists, and yeah, very blessed to work in that team. So my sort of main focus is transplant. I love liver and kidney transplantation medicine. Both the intra-op anesthesia, which is hardcore, and the post-op care. So we run 3 big units at Donald Gordon: a medical ICU, a surgical ICU, and a transplant ICU. And then I'm about to finish a master's at University College London in perioperative medicine, because I realized about 5 years ago that there's people who know a lot more about stuff than me, and I thought I was starting to stagnate a bit. And that's been transformational, and we've done some research at DG now. So yeah, just very blessed to be in my position and to work with the people I do. And yeah, it's been an amazing journey. Lots of cool stories, lots of hardship, but great times.
That sounds like a really, really exciting 20 years. I mean, even just talking about it is like you've done a lot. It's exhausting, but
Yeah, well,
in the
it's
best
like,
possible way. It sounds like, if I can sum it up, you've had an adventure in medicine. It's taken you down 4 or 5 little different diversions and distractions down different paths, and picking up skills and relationships along the way. So definitely at the end, you've come out with a big picture view of everything required to make the ICU the best possible place it can be, and with a good kind of understanding of all the different aspects of preoperative management, surgical management, post intra-op and post-op. So the right kind of person to talk to about everything critical care, as well as get some idea about the different decisions that junior doctors need to make when they're thinking about what type of path they want to take, what kind of decision algorithm they're going to apply.
sure. I think so. I mean, I was 6 years old. I decided I wanted to be a doctor, and I often joke with Law. I say to her, I genuinely think this is not. I don't think I'd be good at anything else,
Yeah,
and
sure.
so yeah. I mean, critical care as a subspecialty, if you do it properly, it demands a lot of your life, and you need a support team that's built over 20, 25 years of you going at this thing. But it's so rewarding,
Mm,
and the people I work with, I mean, the thing about critical care that's amazing, and I'm sure we'll get into this, is that it's really when a lot of us think about medicine, we think about really sick patients in the ICU environment, etc. That's what's attractive about it. It's very stressful, but it's so rewarding. And it's not just rewarding when patients do well, it's rewarding to interact with families at end of life and
sure.
that sort of scenario. That's a real reward of critical care that I think often gets underreported.
Yeah, before we talk about critical care itself in the ICU environment, take us back, if you can, to your junior doctor years. I mean, even as a very young doctor, you were already flying on helicopters and doing exciting things, and making an
Sure,
adventure of it. What was you mentioned that community service was like you were third rounded and you were kicking and screaming towards a rural post in
sure.
northern Natal. But what was it about community service that you wanted to achieve? You obviously had some sort of understanding of where you wanted to go in medicine, and what would have been first choice, and why didn't you? I guess, why didn't you get that first round thing? Was it because you chose a specifically competitive place, or what was it?
So I was single at the time, so I had no family, attachments that would have kept me in a city center. I had applied to do comm service at the time that was part on the road, part in anesthesia. There were only two posts for that in the country,
Part on the
and
road in what sense?
so in the KZN at that time there was a road doctor,
Oh,
sort
wow.
of, yeah, ALS support for the paramedics on the road. And with my background, with my mates, that's sort of felt like a natural extension.
Sure.
That wasn't meant to be. I think I've always had an open mind about this kind of thing. I always, in fifth year, I did an elective in critical care. And I had exposure to mentors like Prof. Richards and guys like Simon Robertson, who's now in Australia for the last 15 years, but guys like that. And I really realized that that's where I wanted to be. But after that, I was actually quite unplanned. I kind of had an open mind as to how I got there. I was kind of like, I'm going to land up there. I feel like it's what's meant to be. And so I'm just going to go with the flow. And so it's interesting. The day that I arrived in Bethesda, the hospital manager from Paarl phoned me to say, look, if you come back, uh, we've managed to wangle a community service post for you here, which would have been awesome. But it's funny, sometimes you have to do the right thing, even though it's the uncomfortable thing to do. because we had 8 people designated for Bethesda that year, and only 3 of us rocked up. So if I'd
Wow.
gone there, there would have been 2, and that would have been a disaster. And I can tell you now, those other 2 doctors and the physios and whatever that I did that time with that year, we're still friends today, and it was a transformational experience. And so I don't regret. We used to fly to our clinics. Okay, so
Wow.
like you must picture this. So you're on the plateau off the Mkuzi off ramp. It's about 50 k's in, and the Makatini Plain on a good day you can look into Mozambique. So it's really northern Natal, and you're surrounded by the other northern Natal rural complex, Manguzi. What were the other 2? I've just forgotten their names suddenly. Anyway, I've forgotten their names, but there were 2 other hospitals, and we used to. There was like a Christian flight service, and they used to fly us to our clinics, like Opanzi and things like that. You land on a grass runway, go and see the patients, and come back. You can't replace what you learn in that environment, and how important it is to become competent on your own in an environment like that. I mean, that year, myself, Kelly, and Ria did over 150 cesarean sections. And
Wow.
I often tell the story, so if you were doing a Caesar at night, you would do the spinal, then you'd walk around and go and scrub, and you'd give the adrenaline or we didn't have ephedrine. So I think we had phenol and adrenaline. You'd give it to the floor nurse, and you'd go and scrub, and you'd cut the baby out, and then you'd go and check that the baby's okay, and then you'd come back while the sister was holding swabs, and you'd stitch the uterus, and they had this thing where they used to make the mom sing in the theater, and if she stopped singing, that was a sign that something was going wrong. And I used to tell that story, and people don't believe it, but it's that kind of thing that's amazing, because we didn't have a single death or cardiac arrest on table in my community service yet.
Wow.
Those gems that are out there, I think nowadays we just don't appreciate that, And anyway, so coming back from that, I knew what I wanted to do. I knew that rural medicine wasn't going to be my long-term life, but I was so grateful for the impact that had on my career, and it matured me, because suddenly there was no one to call, and if you did, they were 400 kilometers away.
Sure.
And so you had to sort of grow up and start making decisions, and then going to 163 was also just, in those days, that unit was hardcore. It was very sought after. 12 MO posts, 50 applicants. I remember interviewing over the phone with Prof. Boffard and really wanting that job. My whole student life, I'd been involved with the guys on the heli and whatever, and so getting to fly on Echo 1 as a flight doctor, and then work in 163 was such an honor, and to work in such a high standard environment was just amazing. I joke with a lot of my mates who are now consultants who I worked with there, and who say, in some respects, it was the most fun we ever had. It was just amazing.
Now, take us back to when you were thrown into the deep end. And it's wonderful that we can look back with hindsight and say, there was not a single bad outcome and things were great. Do you think that your mental health suffered from the pressure at the time, or do you think that it developed a new kind of resiliency in you? I know obviously it matured you and you came out stronger for sure. But at the time, if you had the option to go see a psychiatrist, how were you coping?
So look, I think so for me, I had I suppose I'd worked on the road. I'd seen a lot of trauma and things like that already by the time I'd gotten there, and so I never felt like I was psychologically struggling. I know one of my mates there really struggled, but got through it. I don't know. I think I do think that I think that was the right way to do things. No, I don't think that we should be offering South Africans community service clinicians only in the rural areas trying to wade through really difficult scenarios. And I'm by no means suggesting that we didn't get lucky, that we didn't have a bad outcome. That now as a subspecialist, I can tell you things can go pear-shaped very quickly. I mean, I had to do a surgical cricothyrotomy in my own ICU 3 weeks ago, and I can tell you, I did not see it coming, and I mean, I died 1,000 deaths, and it was a successful outcome, and that's great.
Yeah.
That could easily happen in your community service, and that could damage your career for life. So we just got lucky. I don't think it's the right way to do things, but fortunately for me, I never suffered any psychological issues, but I can very much understand how that could have happened if we had had any negative outcomes.
Sure. There's so much we can unpack after the adventures you've already shared, but let's get to the topic of critical care medicine and running ICUs and the path to that, because there are different ways that you can become an ICU intensivist. My understanding, just so that we kind of build a foundation, is that you can go through any one of 5 channels. So you can go through a surgical route, you can go through an internal medicine route, you can go through anesthetics, you can go through obs and gynae, and then you can also go through emergency medicine. Have I missed any routes, or are those the kind of the 5 ways?
Yeah, so technically you can go through any route. I mean, there's a mate who's a chemical pathologist who
Oh, wow.
who critical care. But those 5 are the commonest. In the US now, about 70% of the intensivists are now anesthesiologists. I think the base specialty lends itself quite nicely to critical care. So does medicine. So those are the 2 commonest.
Can we dive deeper into that a little bit? So obviously with anesthesia, sure, there's a lot of procedures, there's a lot of skills. What are the particular strengths outside of that, particular strengths of anesthesia?
Yeah, so understanding of physiology, resuscitative medicine, those kind of things. On the medicine side, the strengths are diagnostic capability, understanding disease process, etc. But when you merge those 2, then you get some really good clinicians, And so it's the cool thing about critical care is that's one of its most attractive things, is that it's got the high pace, it's got the low pace academia and intellectual aspect. It's got the family interaction, which I think is really cool as well. And then it's got the
soul to it, right?
Yeah, 100%, And I still think that's one of the most rewarding parts of it, And there's negatives. I mean, the hours are ridiculous, and sometimes the stress is overwhelming and the emotional burden can be overwhelming. But again, if you're in the right team, and I mean, we cry with our patients. Just yesterday, I was chatting to one of my peds intensivists. We lost a little girl a few years ago, a couple of days ago. I literally cannot talk about her because I choke up every time, because she really got close to us, And so that aspect, but it's so much of what we're talking about, and this is your perspective. You see, to me, I think that's rewarding because it enriches my life in such a special way. And if that's the kind of person that you are, if that kind of experience enriches you, then critical care is something you should really consider.
Wow. So what would the daily ins and outs of intensive care be? Like, what are your responsibilities? What are the bread and butter things that you see? Obviously, there's excitement and danger at every turn, but what is the core competencies required to be a good intensivist?
So I think we round a lot every day. So we're seeing critically ill patients from medicine, so neutropenic sepsis patients from oncology, and pneumonias and ARDS and things like that. And then on the surgical side, we've got a lot of high risk post-operative management. So hepatobiliary, colorectal, vascular, cardiac. And then on the transplant side, a lot of post-transplant care. So guys that we've transplanted before, who've got immunocompromised and come in with things like invasive fungal infections and other opportunistic infections. And then a lot of our pre-transplant cohort who also come in very sick. So sort of day to day, we're rounding. We've got a lot of staff in the unit. There's a lot of complexity. You're looking at a lot of data. So it's a lot of data analysis. I think in the modern critical care environment, certainly in the modern international environment and the one we replicate at DG, while the patient's in ICU, one of the key roles for an intensivist is to sort of manage the multidisciplinary team.
Sure.
So that's wrangling all the what I call single organ doctors together. They're not really single doctors, but and putting us all in a room together and discussing patient care, and then coming up with a cohesive plan that allows us to sort of give best patient care. And then there's daily patient, family, and patient interaction. That's a very big part of what we do. And then lastly, all the procedural stuff that we do. So every day there's lines, and someone needs to go on ECMO, and someone needs to get ventilated, and stuff like that. So I'd say those are the three sort of pillars.
It's interesting that you highlighted that Donald Gordon is maybe not typical of most ICUs in the country. It's obviously an academic setting with a little bit more resources as well, because it's got private as well as kind of one foot in private and public.
Sure.
Is the ICU environment in South Africa, is it always optimal? What are some of the challenges we face, and how can we improve it?
No, it's not optimal. I think there's not
like many things in the healthcare system.
Sure. And I think one of the key factors, and this goes from load shedding right the way through to what we're talking about, like you've got to acknowledge that you're an alcoholic before you can fix your alcoholism. We got to acknowledge that we, in the main, are not providing care at the level South Africans deserve.
Wow.
And I think that's important to acknowledge. Just as an aside, we do this. In fact, I'm giving this lecture on Friday. We do this lecture at the university on safety in healthcare and how unsafe the healthcare system is. And we use the US data because they're the ones with all the data. And it's always fascinating to me how medical students, when you give them the vocabulary to describe their environments, they tell you what I've just said. These are guys that haven't been tarnished by the system long enough to succumb. And they tell you, yeah, I see this. It's not acceptable. And so, yeah, I think the human resource is a major problem. There's a handful of intensivists in the country. It's very difficult to get high-level care. And the big academic units that exist they give excellent care. But they represent a fraction of the patients that are critically ill in the country. And so one of our big drives in the Critical Care Society, SASA, all these other societies, is to enhance critical care services. But it's not easy because I'll give you, from the time I left school until the time I was a qualified intensivist, that was a 14-year period of training.
Wow.
So it takes a long time to get you trained, and then it's years after that before you are. One of my mentors once said it took him 10 years after subspecializing to stand at the door of the ICU every day and think to himself, there's nothing behind that door that scares me anymore. Wow. And I agree. I think it takes a long time to get guys competent. And then if they leave or they die or they burn out or something goes wrong, then you have a big void where they were. So, yeah, I think we have big problems, but there's also a lot of really cool stuff going on. I've got, there's a lot of intensivists doing fantastic work in the country. So that's also good.
Dr. Brannigan, you indicated, or you just mentioned there, that some of the med students, the way you described it, they're not tarnished. I think the one other way of putting it is that they haven't yet fallen into bad habits or just accepted the culture that is there. And what are some of the things that they've highlighted that junior doctors, so now interns, MOs, comm-serves, visitors to your ICU, what are some of the things that we need to kind of cop on the chin, I guess, and say these are things we can tighten up? I can think immediately of just basic things like our lines, making sure that our lines are secured, that they're flushed, that they're running, that they're not there for too long, that we put them in the right place. Just little considerations like where you place the line to avoid sepsis.
So, Simon, those are the things that make the difference. I don't buy the resource argument. I think it's crap, and I think it's very limited because it's a self-fulfilling prophecy. Let me tell you a story about PCP. So, I entered medicine in the pre-ARV era, and certainly PCP pneumonia was uniformly fatal.
Yes.
And uh, if it weren't for mentors like Prof. Richards, I would have believed the self-fulfilling prophecy that you don't ventilate HIV patients with PCP because they die. And then I ran a unit in Benoni in Glenwood, and I worked with a very good set of physicians there, and we were getting 60% of these patients ventilated HIV PCPs off the vent. Okay, so and we weren't doing anything clever. We were just, like you say, so we were, hardcore with the basics of critical care and sticking in with patients and not withdrawing too soon and availing them of the service. And so I get that resources are a problem, but we in South Africa fall too easily on that excuse.
Mm.
And we need to walk away from that. I mean, a central line. So in my unit, in the transplant unit, you don't run a central line more than 7 to 10 days. And people will argue about the research and the data and whatever, but the reality is that we're maniacal about attention to detail. And that's what makes the difference. And I think that's what we need to remember in our spaces. And when you tell the students this, so when you take this untarnished, optimistic, somewhat naive human being who's very intelligent, who's just entered this period of cognitive dissonance because they have this idea of what they want, what they think medicine should be, and then they see what a shit show it is. I mean, in terms of patient harm, and you give them the vocabulary to describe it, it's amazing what they tell you.
Yeah.
Because talking to my generation is a waste of time because we've all been maligned by the system. And it reminds me that these self-fulfilling prophecies are the thing we have to work against. So when registrars come to my unit and whatever, and we try very hard to be a center of excellence, and we fail repeatedly at it, but we constantly focus on trying to be that. One of the things I say to them is, you've got to, excellence is about an attitude of every aspect of your day. It's not about, the outcome takes care of itself when every aspect of what you do is excellent. When the ward round starts on time, when the blood results are ready and available, when line management is maniacal, when wound management is maniacal, when attention to detail is the norm, when patient communication is consistent, regularly done and compassionate. These are things that make the difference, not the highfalutin stuff that we all think we need to do.
I think, first of all, thank you for that answer. I think that's so helpful, motivating, encouraging. I'm sure that it's inspired a few of us just to improve, even with the little things, and also not to excuse ourselves. Not to say, oh, it's been a busy day, I'm not going to re-drip that patient because the drip's a few days old. Like, no, like you need to really, really have a high standard for yourself and a high standard for your patients. What is, just coming back to the path of specialization, what is it like in South Africa in terms of opportunities to specialize? Is there a lot of competition for reg posts? Is there a lot of competition for those diplomas that you need to get along the way in order to follow this career?
Yeah, I mean, I genuinely feel deep empathy for your generation now, because I think the level of competition it's almost ridiculous. I mean, and I'll tell you why. Why I say it like I'm all for competition. I want the best of the best to come through, but you guys are already that. So by the time you're coming through, I mean, I often chat to Law about this. The GEMP program and all the other wonderful things that have happened. I mean, the medical students that are coming through often blow my mind in terms of what they have achieved already at such a young age. To not give those guys opportunities it's a travesty as far as I'm concerned. And so that's a big area, is creating access for opportunity to train. That's one of our big pillars of drive at Donald Gordon. and I know, I mean, for Sue Tager, who's the CEO, this is like a major driver of her average day. So I think it's a big issue in terms of the competition. It is competitive. You know, you've got to get through your specialty. You've got to do well. Then you've got to get a subspecialty post. The fellowship is hard. It's, you know, my fellow at the moment, I mean, she'll tell you, it's not fun, but it's rewarding. And that 2 years, basically, you live in the intensive care unit. And
Sure.
I think, but I do think we need to create more opportunities for young clinicians. You know, I'm very
Yeah.
worried about it. I want to see,
Yeah.
I would love to have 5 fellows.
Wow. And without getting either of us into trouble, just on this point, I want to share, because so please don't say anything, but I just want to share a story that I encountered today, which I thought was absolutely wild. I saw that an academic hospital, or yeah, I don't want to give away too much information, was advertising unpaid volunteer MO posts with the perk of getting taught how to do certain procedures and getting supervised training. But they made it clear this was an unpaid volunteer MO post that you would be doing in order to get your time so you could write your diplomas. That's just wild.
Yeah, so I'm not worried about getting into trouble. That's ridiculous. We live in a
Yeah.
country where, you know, I actually said this in theatre today. If we gave jobs to every single medical officer qualifying now, and every single one of those people got specialist jobs, and we did that for 20 years in a row, we would still not meet the requirement for fellow South Africans in terms of healthcare. So to have medical officers out of work in South Africa means that we, as the medical system, the Department of Health, the government, we're failing South Africans. And that's just the bottom line. And it's, you know, it's unthinkable that we have trained these people that are coming through who are intelligent, hardworking, motivated, and qualified, and we can't give them jobs. I mean,
Yeah.
so again, at DG, you know, we've just embarked on this thing. I know Discovery Health is working very hard as well in the private sector to try and create the infrastructure to give medical officer posts. But we've just expanded our medical officer platform at Donald Gordon, and I can't tell you how wonderful those medical officers are. They're just amazing, and I can't often get them into reg posts because there's this like blockage, you know. And it's just not good enough. We need to do better.
Yeah. Thank you for that. So moving on to some of the questions we prepared beforehand, I think we've touched on some of the potential negatives, some of the problems in the system. What is the hardest part of your job? You've spoken about how wonderful it is, but there must be some pain points, some things that you like, yeah, this just sucks.
Yeah, I think I'm a dad to 2 beautiful children who don't get to see me enough, and I mean, you're a dad as well. You'll know that there's been moments where my kids have said to me, where you can just see it, or they've vocalized it. They're 12 and 8 now, so they can voice their frustration. My family will tell you that having me at an event is rare. So that really sucks. It's a big sacrifice that I've probably missed, I would say, half the last 20 Christmases
Wow.
and Easters, and there's lots of night work and rushing out at 3 a.m. That's hard, you know, but luckily I have in my wife, I have a support structure that is just amazing, who's constantly telling the children that dad's a good guy, so that helps. But I think that's the hardest part for me, is that my family suffer because of my work. And then when you have patients who you really connect with and their families, and they don't do well or they demise in the unit, that can be very burdensome on the soul. And I think for me, it's more, it's not a psychological thing. It's more yeah, I think that's the way to describe it. burdensome for my soul. I think there's many patients who I've shed a tear for, and whose families I'm been very close to, and I think that's hard. As much as it's rewarding and as amazing as it is, and to be able to share in those moments with these families, that's very hard. It can break you, you know? And there are times where I've walked away thinking this is too hard. You know,
Sure.
this hours are too long, and the suffering is too much, and whatever. But then you get you also have a story. A patient contacted me 2 weeks ago. Not to give away anonymity, but this little girl, she was a teenager when she got very sick in another hospital, and they flew her into my old ICU, and we ECMO'd her, and she had a cardiac arrest on the helipad.
Wow.
And I remember walking out, we had put her on ECMO, and we'd gotten her stable hemodynamically, and I sat with the family outside, and I was dealing with a mom and dad who were devastated. And I said, I'm very worried because there's a fate worse than death, and that's that your daughter might survive this so impaired that it will seem like it's not been worth it. You know, she was a young teenager at the time, and she's just finished university, and that will transform your life to have that conversation.
That's incredible. Thank you so much for being so vulnerable. I'm going to take a little bit of liberties because you are sharing so much. What are some of the coping mechanisms that when things are particularly tough, what are some of the ways that you just build resiliency in yourself, maybe relieve some stress and keep yourself strong?
Yeah, so alcohol works. I know, I'm joking. But you do have to have a penchant for a good time. I think I love. I have very good friends and in medicine, and I come from a group of guys who all. It's fascinating. They're all wild. All did really well at medical school. Very bright guys, but can also have a good time. So they know how to relax, which is important. But I train hard. I go to gym a lot, and I exercise. For me, that's been transformational in terms of my mental well-being. And I think we underdo that in healthcare. And in fact, I often say to Sue, she needs to create a gym at the hospital. I think that would make a huge difference for doctors. And then my family's amazing. And then my religion. I'm religious, and I have deep faith, and I rely a lot on that for my spiritual resilience. And yeah, that's what I do. Yeah.
That's all tremendous answers. And I think that you're right. We, as doctors, we're far better at prescribing exercise and diet and good sleep for our patients than for ourselves.
Sure. It wasn't always like that. I used to, I mean, I when I flew on the heli, I used to smoke, and I neglected my health, and I landed up in my own ICU a few years ago for a short period. And something just clicked, and I realized the pace of this, and the stress and the tension required me to maneuver in other ways. And so started getting healthier, and started focusing more on my own mental health, and that really changed my life. And then realizing that the people around you actually are the people that you need to lean on for your mental health. They carry the burden for you when you can't, and vice versa.
I love that you mentioned your faith. We do go to the same church, but we're not often there together because of different hours.
Sure.
But have you ever prayed for a patient and had an answer to prayer where you can say there was no ways that this patient should have made it medically, but there was some supernatural intervention there?
Oh, I can. I mean, I can tell you. So I pray for patients every day. I have a rosary that I take to work. I pray every day. I constantly engage with the man at the bedside. Sometimes I feel like he's falling asleep on the smart button, which is what I tell the registrars. But yeah, there've been a few moments in my life where, notwithstanding the cricothyrotomy I spoke about now, I mean, I'll tell you a story. I had to go and intubate the ex-president, Mr. Nelson Mandela, in the middle of a resus scenario years ago, and I know in that moment in time, I mean, I was petrified, and I was standing next to a medical officer who was equally beside herself, and while we were opening a crike set, we were going to land up criking him. I grabbed a tube off the table and I just said, "Look, I don't know what else to do." And that blind nasal tube, it landed up being a blind nasal. I never saw his cord. Popped in, and you walk away from something like that, and you think, how can you not see that you are just a conduit?
Yeah.
I've had that happen many times where I know that, and I'm sure there's many people listening to the podcast thinking, "Wow, this guy's crazy," but that's also fine. We're all on our own journey. I mean, I just know for myself, there's been many times and moments where the outcome in my human mind was not possible, and yet it manifested, and things where afterwards I realized that my own skill set was not adequate to achieve that, And so now in my mid-40s, it's an interesting time to be a mid-career specialist, because in some respects that's very calming, because I'm not so invested in the outcome. And I think you spoke to me earlier about psychological resilience, and I think, well, that's the thing. I'm like, I don't connect myself so much to the outcome. I accept the outcome and I do whatever I can to the best of my ability and pray that the rest will be taken care of. And for me, that's very calming.
Mm.
I hope that answers your question.
No, such a great answer. And I think just through conversation, this is one of the benefits and the beauties of the podcast. I think that we don't often get an opportunity to pick the brains of our consultants in this kind of setting, in this kind of manner, where just the human aspect of it and the experience comes through. An academic setting is useful in many regards, but to really get the human experience side of things, because the experience that you're sharing now is something that you wouldn't necessarily have a tat on. What would the title be? And so
Sure.
so you mentioned being a mid-career specialist, and obviously every journey is different. People are entering it at different ages and from different backgrounds. But what is the career arc, do you think, if you could typify what a career arc looks like in medicine in South Africa? How would you kind of, and maybe even attribute time frames to it? So you can say for the first X many years, you're this, and take it from there.
Sure. Yeah, it's a great question. I think I often talk about this because I say to the registrars now, they're not the same registrars that when I was there, because many more of them are parents already. They're in long-term relationships already. I was married as a reg, but I had no children. It's a very different world. I mean, you yourself know many young clinicians have kids, their parents, and in some respects, in my own life, I've had to try and adapt, made lots of mistakes trying to engage with registrars as if they were from my era, which is incorrect because a lot of them are not. Just the career arc is basically like this. So you go to medical school. I think there's more and more mature students, which I'm a big fan of, because I think you guys do better. In fact, the data, law tells me the data suggests that the more mature students do well for up to 10 years after they qualify. And then if you hang around in a medical officer post for a bit, where you're learning a bit, but you master sort of at your level, and then you enter your reg post, and that's where you're going to do 4 to 6 years of real intense training, and that's really where you galvanize your, if you do it properly and you get into a good unit, where you galvanize your sort of your intellectual academic side of what you do, and you start to get really good at your skill set. Once you're done with your reg time, then it's about galvanizing that. And I think on average, that takes about 5 years after that to get to the top of where you want to be.
Sure.
And if you do an intervening time, like a sub-spec, it takes another 5 years after that. For me, it took 5 years after sub-specializing before I fell off Mount Stupid, as Kruger Dunning says, and
Into
sort
the
of
slough of despond.
correct, and sort of recovered to a point where I was comfortable with what I could and couldn't do.
Yes.
And like my mentor said, not nervous about what was behind the door, because you get to a point where you recognize that there are some things you're never going to know, and it's okay. You can manage it because you're mature enough and you have resilience and enough knowledge to be able to manage the situation. And you have developed a repertoire of people you can call.
Yeah.
So I think that's the sort of career arc. So now where I am now is interesting, because a lot of the trap in mid-career is to start thinking that you can't learn anything. And hence my doing this master's, which was transformational for me. I mean, it really opened my eyes to blind spots of ineptitude in my own knowledge base, and again rekindled that sort of almost medical student like curiosity in learning again, which was amazing. And so I've done some research now and on that, and I think a lot of middle career guys start to stagnate a little bit, and then I think your arc starts to fall off when you realize that you can't do the long hours anymore, and you now need to start planning your life around. I'm very much involved in SASA's approach to the older clinician and the impaired clinician.
Wow.
And we're developing a program around that to try, because we don't do that very well. We don't look after guys as they start to age, and the data is really good on this. So we need to start looking after that arc. And I have a lot of older colleagues now who are so awesome in terms of what they can offer, but they can't compete with me at 100-hour weeks at 60.
Sure, and that's just a practical thing. They don't have the physical strength.
100%. I'll give you a stat. If you're 40
yes,
and you go 24 hours without sleep, you recover in 24 hours.
Okay.
When you're 50, that takes 3 days to return to your cognitive baseline. So,
wow.
And we compensate so much for this stuff in medicine, and I'm starting to feel it now at 45. I'm definitely at the end of a week of call in ICU, I'm definitely more fatigued than I was when I was 35. And so it's just about managing that, it's about, like you mentioned earlier, about the 4 or 5 hours sleep thing. Exactly that, in my week of ICU, if I get 4 hours sleep a night, I'm cool, I'm fine, I'm performing. Come the next Monday, I have to now insist that I take the night off. I don't do any academic work and whatever. I spend time with Law and the kids. I'll have a whiskey, go to bed early, that kind of stuff, and look after my mental health, and then I'm fine. So I think that arc is another part. And then finally, the last part is easing into retirement. And that really should happen over 5 years. If you devote 100 hours a week for 25 years of your life, 30 years of your life, you can't just switch that off.
100%, yeah.
What other professions don't get about what we do. For most of us, you and me, lawyers don't get this, financial guys don't get this. And is that for you and I, this is not a job. This is part of who we are. So we can't just switch that off. You have to understand that if you want to know me, that's part of who I am. It's not just what I do.
There's so many things to kind of unpack in what you've said. So coming all the way back to the Dunning-Kruger effect, and for the benefits of the medical students who are like, what on earth is that? If you can imagine, a y and x and y, where y is how confident you are in your ability, that's the vertical axis, and the x-axis is how much you actually know.
Sure.
In that initial, I'm just describing for the benefit of our audience, in that initial, let's say 100 hours of learning and experiencing things, there's a massive increase in your confidence, and you feel like, I really know this, but you only know a small fraction of what there is to know. And as your knowledge increases and you realize what you don't know, you fall into this slough of despond, this valley of despair, where you go, oh my gosh, will I ever get to know everything there is to know this? And the climb back up into confidence is very, very gradual, very slow. And that's why oftentimes the most humble person in the room is the most qualified. You know,
Oh,
on the ward round, the consultant is the one saying, what do you think about this? And he's actually listening to everyone saying, that's an interesting perspective. I didn't really think of it that way, because he knows it's taken him 15, 20 years to build up all that knowledge he has.
sure.
Taking that, so it's taking the
Yeah,
Dunning-Kruger effect now and applying it to medicine. Should we all try and get 100 hours of expertise in everything? So a good generalist will try and get as much information as you can from as many different fields as you can. But it can, and this is maybe the danger, can cause you to think you know more than you do, and you're a little bit overconfident. So you run the risk of being the super confident MO junior doctor. Or
sure.
is the right way to go that granular, when you really subdivide medicine into the little silos, and as you jokingly called it, the single organ doctors.
Sure. So it's a problem. I mean, the generalist versus subspecialist debate, and in fact, it's getting ridiculous because, there's this joke around the left ear surgeon. You arrive with your right ear injured, and they say, well, only the left ear surgeon's on call. So I think that, look, I'll tell you a stat that I found fascinating. It goes something like this. It took us, if we take everything we knew about the human body and medicine to 1750, that took till 1950 to double. By the year 2000, we had doubled that knowledge. 2010, we had doubled that knowledge again. 2015, we doubled that knowledge. And at the current rate of growth, it's something like every 18 months that we. So the mere concept of a good generalist is also very flawed, because I don't know that we can really call that, the really good family physicians, etc. They're not really generalists anymore. They themselves niche within their own specialty. If I look at myself, I don't work in a medical ICU anymore, because the physician that runs a medical ICU at Donald Gordon is one of the brightest people I've ever met. That's what he does. I can't compete with that anymore. And this concept of divergent specialization silos us away from everyone. And that's where it's very important to create systems that pull us all together. So when we round at Donald Gordon on, say, liver transplant patients, you've got a hepatologist, often a nephrologist, an intensive care specialist, a transplant surgeon, a microbiologist, and that's just mentioning the doctors. I'm not even talking about the physio, the dietitian, the OT, the nursing staff. So you have all these people with very specific subsets of knowledge. I think it's a big problem for where we are today. Do we need good primary healthcare? Absolutely. But that's not the same argument as the generalist specialist debate. The reality is that you've got to get really good at one or two things. And that's what you get good at, I mean, when I first qualified as an anesthesiologist, I used to dope a lot of neonates.
Wow.
I won't touch a neonate with a barge pole now. Even though I have the paper to say I can do it, I haven't doped a neonate in 5 years. I just wouldn't be able to do it safely to the level that my colleagues who are doing it could do it. I think we just need to appreciate the world we live in. And I often say this to Law, because Law's in the education space, as as a physician, the biggest problem they face is, how do you take this old curriculum that taught people like me to become good generalists, and then we subspecialized? How do you take that curriculum and adapt it to a world where every 18 months things are changing so profoundly that you can't keep up? And that's before we even begin to discuss AI, VR, all this other stuff that's transforming the education space.
Yeah. I think it's so important for any medical student listening to this podcast to recognize and to know that the educationists, the educators, that's the correct English word, the educators trying to train them have actually got their best interests and the patient's interest at heart. Because too many times the medical students are complaining about how tough med school is, and these, these old farts are just trying to force the old system upon us. But really, the medical training space is a very large ship that has a big turning circle and is very difficult to maneuver. And the world is moving extremely fast. So they are doing the best they can to be nimble and agile and kind of adapt. COVID turned everything upside down as well. But the
Sure.
just the sheer volume and rate of knowledge is overwhelming.
But like you said, when you're at the bottom of the pile and you've got a bit of knowledge, that's when you think you know everything about it. I mean, we were all like that.
Yeah.
When I was a medical student, I thought that some of the profs had no idea about the way that we needed to be trained, and I think it's more important just to be aware that we're all susceptible to things like trigger dunning and whatever. And the moment you feel that thing coming on, like that's actually why I did my master's, because I was like, I think I'm pretty good at this, I'm like 40. I think I'm probably not the best, but I mean, in the world of South Africa, I think I pretty much know a lot about perioperative medicine, and I'm a good intensivist and whatever. And then whenever I get that thought, I think to myself, really, maybe there's something more to know. And then you open a new door and you realize there's guys who are speaking a language you need to learn. And it's fascinating. I sat with Noah the other day, my little boy, because he's this coding genius, which is amazing. And I've decided I need to learn how to code in Python,
Oh,
because
wow.
how do you keep up in the modern world if you can't code, kind of thing. And it's been astronomically difficult to sit there and learn. And I watch him doing this next to me, and it comes so easily to him. And so it's just about constantly realizing that whenever you feel comfortable in your knowledge base, trust me, you need to expand. You've just gotten too big for the room you're in, and you need to find a bigger room.
Yeah, amazing. We have gotten so much gold out of you in this episode, so thank you so much for the interview. I think, just for the sake of your time, we need to start coming towards the end. I wish we could maybe split this
Sure.
into a series of podcasts. Maybe we'll have you on again soon.
Sure.
Maybe a little bit more focused discussion as well, where we hammer
Sure.
out on one topic. But just towards the end of this conversation, what do you think it's important for, and we've touched on many things, but what do you think it's important for medical students and junior doctors to take with them and to get out of this episode, if you were to try and summarize it into one major point?
Yeah, so I think don't. I think that there's a couple of do's and a couple of don'ts. So I
Okay.
think that it's better to start with the don'ts. That's where we all start in the beginning of life. Don't think you have to have everything worked out and that you have to have this clear path. And like we're all type A personalities, we're all intelligent, we all do well, And the tendency for that is to want to control everything, and you don't need to do that. Life will unfold in interesting ways if you just open your mind and heart to that, and you'll get where you need to go if you just open your heart and mind. And don't sweat the small stuff all the time. There's a lot of stuff that happens in medicine, and it's difficult, and there's months where it's not great, and if you just hang in there and stick it out, it generally works out very well, and it can be very rewarding. And then I think just be consistent. I
So
think
these are the do's now, the do's.
yeah, the do's, I think, are just be consistent, in sort of your academic focus. Like, don't try to learn everything in one day. Just be consistent every day. Just do a little bit, and you'll be amazed at the sort of compound interest effect of doing that. And I wish someone had told me that when I was younger. I did that as a fellow, and it paid off a lot. And then remember to have fun. I think if you were to ask me, I think we've lost a bit of that in medicine. The ability to laugh in a tragic situation is not. We need to not be so easily offended. Okay, we need to remember that we work in hardcore environments. We love people. That's why we do it. But it's also fun. what we get to do behind the no authorized entry doors is a lot of fun. I get to go and do liver transplant anesthesia with some of my best mates every week, and then get to manage them in the ICU. I mean, we laugh a lot. And if you remember to laugh a lot, then when you're crying, and that'll happen enough, you will, I don't know, just get a lot more out of the environment, you know. You don't have
Yeah.
to be so serious all the time.
Yeah, I love that. Yeah, I'm all for us being kinder to one another, and not trying to hurt anyone's feelings, but also and I think it's come through in this episode as well, to be okay with being a bit cheeky,
Yeah,
and to have enough of a thick skin to know if somebody says something, to be like, okay, that's a perspective.
yeah, and Simon, let me tell you, I'm not preaching when I say that, because I've been on the receiving end and on the delivery end of that, where, that's the other thing. Like, if people think that heads of departments and people like that don't cock things up often, and you're mad. I mean, I've had interactions where I've walked away thinking, wow, Brannigan, you've handled that really badly, And I think it's just about trying to learn from that, coming back in, having a little bit of self-forgiveness and saying, look, I handled that really badly, but I also have handled things really well, where I've walked out and thought, gee, nailed that, was really good at mediating a very difficult scenario. And I think we're very hard on ourselves when we get things wrong sometimes. Instead of just saying, cool, I got that wrong, let's move on, let's not get it wrong again.
Yes.
Um, and this cancel culture where, like, someone says something that offends you and then it's overs in terms of your ability to interact, that's just nonsense. We need to
Yeah.
be a bit softer on each other, and we need to listen. I had a registrar. It's fascinating. I'll tell you just a quick anecdote. Generally speaking, we get a lot of really positive registrar uh, reviews and whatever, and then suddenly we got this really negative review. And I was chatting to a mate of mine, and he was like, it's crap and whatever. And I said to him, I think this is the one we need to listen to the most, because it's good to have naysayers, and it's good to listen to that. And you don't have to agree with everyone who disagrees with you. And
Yeah.
I have views that I'm sure people disagree with a lot, but I think we'd do well just to chill out a little bit.
Awesome. Love that. If I could ask you if there's any books that you've read that you found particularly helpful, and I understand you're working 100 hours a week. Maybe there's not a lot of time for reading a book, but listening to a podcast or a resource, or even just a funny YouTube video that really you found useful.
Sure.
Anything that you could share with the audience that had a lasting impact on you?
So I read prolifically and I listen to podcasts prolifically, because I think you can learn so much by doing that. I think
Do
if
you
you're
ever
not
listen to podcasts you don't agree with?
all the time.
Okay.
So if you're so I have a kind of rule.
Yeah.
If you open your Instagram account, or you jump on YouTube, and everything you're watching, you get up and you go, oh, I like that. Then you're living in an echo chamber. So
Yeah.
you need to not do that. So that's something to look out for, in my opinion. And you want to put some people in your, particularly if you're in a head of department position or leadership position, you want to keep some naysayers in the unit around you. I have one guy in my team that basically, if I say left, he'll say right, and and it's good, because maybe 20% of the time he prevents me from walking into a buzzsaw, which is good. But yeah, I read a lot and I listen to a lot of podcasts. So the kind of things I've read that have transformed my life, like I read the Gulag Archipelago by Alexander Solzhenitsyn, very difficult read.
Yeah. Well, it's from a different era. So
100%.
even the language, it's almost like foreign to today's society, because we haven't really had a world war and anything to
Sure,
recover from.
sure. And then another book that I read, which I thought was also amazing, was what's it called now? Few Good Men, about the police unit in also in the Second World War, from that traversed Poland, because it's quite interesting to learn about how people harm each other.
Sure.
Viktor Frankl, I read a bit of, Nietzsche, a bit of.
There's lots of heavy thinkers in your reading list here, Doc.
Yeah, because about 10 years ago, I realized that these guys have written some stuff which is just next level. You know, they've devoted their whole lives to it. A lot of them are crazy as well. But I mean, you read Dostoevsky or Nietzsche. It's very difficult to read. You start to think about the world differently. You know, and then law's gotten me onto starting to look more at fiction. So, which 10 years ago I didn't think was any good, but now I think is very good. And then I watch a lot of YouTube discussions on religion, on humanity, on AI. I'm a huge fan. I've just put all my letters of motivation on ChatGPT. And you know, I don't know. I just think it's such an amazing time to be alive. If you're not reading and engaging, like, what are you doing? You know, because you're missing out on probably the most profound informational age known to man. And so if you're not engaging in information, and the way we do that is through books, podcasts, access to the internet, etc., then you're really asleep and you need to wake up.
Yeah. Dr. Brannigan, it has been an absolute pleasure to have this conversation with you. And I think if I can summarize what I've gotten out of this conversation is just the human aspect that is so apparent in everything that you say and everything that you do. I think that the ICU environment is a deeply spiritual place. It's a place where you're literally standing at the doorway between two worlds, and you have carried yourself commendably through a career that is, you describe as mid-career, but I wish you all the best in advancing years, and may you age wonderfully and wisely. And I look forward to working with you in future and learning from you as we go. Thank you so much for what you've invested time-wise and just wisdom-wise into the young doctors who are listening to this podcast. We really appreciate it.
I can't tell you what a privilege it is to chat with you. And for all the young doctors out there, just hang in there. And if you ever need anything, just give me a shout.
Thank you so much, Doctor.